Hi everyone, and welcome to this first webinar organized by the Health Economics Exchange Forum for the Afghanistan Ministry of Public Health. The Health Economic Exchange Forum is a platform to stimulate discussion among health financing experts in Afghanistan, as well as from countries in the region. My name is Caroline Philly. I work from the Health Sector Resiliency Project, and I will be your facilitator for this event. Let me just first start with thanking the USAID Health Sector Resiliency Project, who is sponsoring the event, as well as the Ministry of Public Health, who is making it possible. So the subject of today's webinar is the implementation of user fees at secondary and tertiary level at hospital. Why are we discussing this topic? Because many developing countries, such as Afghanistan, are looking for ways to increase domestic resources for health, as demand for quality services is increasing as external support decreasing in many countries. Collective fees at hospital level is seen by its proponents as a way to more efficiently collect resources for the sector, while strengthening the overall system by rationalizing the use of care. Today, we will discuss in more detail what countries hope to achieve with user fee reforms through the example of Afghanistan, and we will learn from the international experience about success factors and challenges that other countries have experienced. We'll spend some time as well getting more insights about the experience of Cambodia, a country where user fees have been implemented for 20 years, along with programs to ensure that the poor are not left behind. At the end of this, we will have some time for question and answer session. Before moving to giving the floor to our participant, let me just guide the attendees on how the GoToWebinar system works. So you should have on your right-hand side a control panel that you can hide and unhide using the red arrow. You also will be able to ask us questions. You have a question box. Please ask question along the presentation. We will spend some few minutes after each presenter's intervention just to ask for clarification. And at the end of the session, we'll spend hopefully 20 minutes to have a discussion. Please, if your question is directed to one of the presenters, type this into your question to facilitate the flow of question. I think we're all set with the logistical question. As well, if you're experiencing problem with the system, please also reach out to us to the question box. We'll try to help you to make this smoother. So let me present you who is with us today. We are very proud to have with us 4 key speakers. So unfortunately, His Excellency Hamad Jan Naim could not make it for the event. There was another very important appointment that came up. So Dr. Sahid Mohammed Karim Alawi will just speak on his behalf and give us some keynotes on the event. We'll have then Dr. Wu Zheng from the USAID Health Sector Resiliency Project that will guide us through what is the international experience on user fees. Then Dr. Jordan Hood, who is the Chief of Party of the USAID Social Health Protection Project in Cambodia, will guide us through the experience in this country. And we'll have some ending notes about Dr. Farhad Farwar, who is the Director of the Health Economics and Financing Directorate in Afghanistan. Without taking more time, I'd like to give the floor to Dr. Saeed Muhammad Karim Alawi on behalf of His Excellency Deputy Minister to give us some keynotes. Thank you.
Thank you, Caroline. Good afternoon, everybody. On behalf of His Excellency Deputy Minister, I, Dr. Alawi, Head of Resource Tracking Unit of Health Economics and Financing Department of Ministry of Public Health of Afghanistan, would like to open this webinar. Globally, countries are finding different ways to gradually proceed towards universal health coverage, and Afghanistan is not an exception in this endeavor. Between 2003 and 2005, Afghanistan introduced basic and essential packages of health services, which have been delivered through public health facilities. As a result, notable improvement can be observed in service coverage and health status of Afghan population. Currently, all the services provided through a wide network of health facilities from the health post to national hospital are free of charges to the public. Despite this policy provision, out-of-pocket expenditure is still very high, which is 72% of total health expenditure based on latest National Health Account estimates. Such a high level of out-of-pocket expenditure is a major policy concern for the Ministry of Public Health and also for our development partners, as it puts the household at risk of financial catastrophe and impoverishment. Nevertheless, government has not been able to allocate adequate funds for the health sector, and it is currently at 5% of total government expenditure, which is supplemented by donor support. Due to the limited funding available for the public health facilities, quality of care remains a major concern. Given this context, Ministry of Public Health of Afghanistan has considered the introduction of user fee at the hospital level, particularly those providing secondary and tertiary level, with the following major objective, mainly improving the quality of services. To generate discretionary fund within the hospital to improve the quality of care, to sensitize public on the cost of services and encourage them to use cost-effective primary care services, as free will not be charged for primary care, and also to incentivize the health workers to be accountable and responsive to the healthcare needs of the public. Ministry of Public Health want to pilot the user fee in number of national hospitals to learn by doing. This webinar is a very timely for us and can provide secret for the successful implementation of user fee based on international experiences. Thanks to my colleagues from the Ministry of Public Health for organizing this event, and would like to appreciate the support of Health Sector Resiliency Project to make this event happen. I look forward for the productive discussions and learn more on this topic. Thank you.
Thank you so much, Dr. Alawi, for the introduction. So let's dig into the subject right now. And I'd like to invite Dr. Wu Zeng to give us some insight into what international practice is telling us about user fees. Dr. Wu, floor is yours.
Thank you, Caroline. In this section, I'm going to present some evidence from other countries in terms of the implementation of user fees at the secondary and the tertiary level. Next slide. In this section, I will start with fundamental questions of the user fees, amplify the basic theoretical framework of user fees using a graph. Then I will present some evidence about the impact of user fees on utilization of health care, quality of care, and equity of the services utilization. I will then spend a few minutes to discuss a case of user fee implementation in hospital in Cambodia. Finally, I will summarize the presentation with a few key messages. Next slide. When introducing user fees, the general population may ask this question: are user fees good or bad? And the policymakers also need to answer this question as well. Let me start with the definition of the user fees. User fees are defined as any contribution to the cost of the services provision by users at the point of the service delivery. In this case, it is hospitals. So, which means any payment when a patient seeks care at hospitals is regarded as a user fees. It should be noticed the user fees are not equivalent to the cost of the service delivery. They can be equal to, below or above the cost of services delivery, cost of services. For example, for private hospitals, user fees are generally higher than the cost of services, so that the hospitals can make a profit. In a country with the health insurance, the charges are often lower than the cost of the services, as the insurance company pays the large portion of the cost. Next slide. There have been a huge debate on user fees globally. Those who like the idea of the user fees generally claims that user fees can supplement to the inadequate financial resources for health. Shortage of drugs and human resources are quite common in developing countries. With the additional money from user fees, they can address some of these issues. Secondly, user fees can make a health system more efficiently by guiding demand to cost-effective health care. With user fees, patients are more conscious about using the health care. User fee can set differently according to the level of the care. For example, some countries have set the higher user fees at the tertiary hospitals, while have a lower user fees in the secondary. So in this case, more patients will come to the secondary hospitals to seek care. Thirdly, user fees could be used as a means to control cost. Without user fees, there is a high chance that patients may abuse the healthcare system and use unnecessary healthcare services, driving cost of the healthcare at a high level. Economically, this phenomenon is called the moral hazard. User fees makes patients be more conscious about the care they're going to use and control the cost, because the utilization may drop after the introduction of the user fees. Lastly, user fees can potentially improve equity if the revenue raised from user fees are relocated to address the health need of the poor. For those who don't like the user fees, the journal claims that user fees price the poor out of the market because the poor cannot pay the services, so they are not able to get to the hospital to seek care. They also often claim that the revenue collected from user fees was a small amount, probably less than 10%, and user fee does not necessarily improve the quality of the health care. Although the user fees can be used for the health services for the poor, but the effective relocation is quite difficult to implement due to the administrative barriers. Next slide. So I'm going to show you a graph which presents some basic theoretical framework of the user fees. This is the demand curve with the horizontal line as the price. In this case, would be vertical line as it's a price, and the horizontal line, that is the utilization of the health care. This is the downward demand curve, which means with the increase of the price, the utilization will goes down. Now you can see the price at 0, which is means that at the second stance, no user fees. Based on this graph, the utilization of care will be at the point of the Q0. Now let's increase the user fee a little bit to the level of the P1. That is the yellow box you can see here. With the increase of the user fees, the demand curve can shift as well. In this case, I present two scenarios: shift to the right, which means the quality of the care got improved and actually attract more, can possibly attract more patients to seek care. One scenario was a small change of the quality of care. The other scenario has a large change of the quality. So the demand curve shift outwards substantially. Then you can see from this graph that two possible results come out. One is the utilization of healthcare is below what is originally before the user fee, below Q0. However, there is also another circumstance. That is in a situation with a large improvement of the quality of care, the utilization is at the Q1B level, which is above the Q0. To summarize, the user fee has two major impacts. One impact is about the price. So if everything doesn't change, the price goes up, it is likely the utilization will goes down. But we have to also consider another impact, which is the quality impact, because user fee can also possibly bring about the quality improvement, which will improve the utilization of healthcare. Next slide. Let's look at some evidence from other countries on user fees. Next slide. User fees are still widely used in developing countries. In this picture, it shows the implementation of user fees in Africa in 2009. The country with a green color are those still having user fees prior to 2000, Tanzania and Lesotho. These two provides the free care before the year 2000. The 7 countries are in red. Those countries are those implementing free care since 2000. But you can see here, most of the countries are in gray, which means these countries are still using user fees. Next slide. Well, there are many articles talking about the user fees at the primary level, but at the secondary and tertiary level, not so many articles are available. We reviewed 9 studies from different countries to examine the impact of user fees on utilization of healthcare in hospitals. These studies from 9 countries, including Cambodia, Uganda, Hungary, and so on. What we found that is the impact of user fees on utilization of the services are quite mixed. 2 studies show the positive impact, suggesting that the user fee improve utilization of healthcare, which is in the case of the Cambodian and the Ethiopian. While there are 4 studies showing that user fees are leading to a reduction of the utilization of the healthcare. There are 3 studies shows no major impact of the user fee on utilization of healthcare. It should be noticed that these 2 studies showing the positive impact of the user fees has a very clear supplemental policies to provide exemption for the poor. Next slide. What is the impact of the user fees on the quality of care? In developing countries, patients often complain about the stock out medications. If the stock out is the major concern of the quality, and then the user fees can be used to improve the lowest quality issues. But we should notice that user fees do not have a direct causal impact on the quality of services. The impact of user fees on quality, it is through how the user fees are spent. If they spend for the quality improvement, the quality can be changed. But if the user fees are used for other purpose, if it's not used for the quality purpose, then there's no way to improve the quality. That is why it's important to have a regulation on how user fee should be used. To minimize the concerns of the user fees on can you go back, Caroline? Yeah. To minimize the concerns of the user fees on use of the care quality improvement activities should be simultaneously implemented in order to make sure the quality is improved and make sure the demand curve is shifted to outward. Next slide. What is the impact of the user fees on equity then? Without any supplemental policies for the poor, because the price increase of for the services, definitely it will drive the poor out of market. That means the poor cannot access to the healthcare services. There are two major remedies that has been implemented globally. One is to provide exemption or reduction of the user fees for the poor. If they cannot pay, probably they don't need to pay for the health care through kind of a mean test. Another approach is to establish the health equity fund. So using the funding from this fund to pay for health services for the poor. We also should notice that with the additional resources collected from user fees, this amount of money can be pooled and provide a subsidy to the poor and vulnerable populations. So at the end, the ultimate impact of the user fees on equity issues depends on the economic status of the patient. If the patients are rich in a facility, the impact of the user fees on them will be minimal. The second, it also depends on the provision of the exemptions or subsidies for the poor. Next slide. Let me spend a few minutes to look at the case of the user fee implementation in a hospital in Cambodia. I will quickly go through it because Mr. Jordan Wood will talk more detail about the Cambodia case in the next presentation. Next slide. So this case study took place in a National Maternal and Child Health Center of the Cambodian. The user fee policy was implemented in 1995. Before that, all the services are provided for free. This is very similar to the circumstance in Afghanistan. And the purpose of the using user fees is quite common. It's to reduce the government financial burden, to improve the public health sector management. And I also want to point out the one background information before introducing user fees. Because the staff has a very low salary, they often ask for the informal payment in a hospital. Next slide. This project was funded by JACO, and the implementers took very careful consideration to adjust the quality of care and the equity issues. It has a regulation in terms of how to use user fees. Here you can see that about 50% of the fees collected are used for the salary, to compensate the salary. About 30% of the user fees are used to implement management and quality control. The 20% is to adjust the stock out issues of the medication in the health centers. In order to adjust the equity issues, exemption policies was also in place. For the poor, they are exempt from user fees. There are also some other group of population are exempt. Next slide. This picture shows the utilization of the delivery and the bed occupancy rate before and after the implementation of the user fees. The gray bar represents the number of delivery in each month, while the line represents the bed occupancy rate. You can see here, before the introduction of user fees, both indicators are quite stable at a certain level. After implementation of user fees, which the two indicator did not reduce. Instead, it's going up steadily, which suggests a positive impact of the user fees on utilization of healthcare. Next slide. Some may argue that the increase of the the services are probably due to the induced demand to the doctors from the doctors, because doctors are more knowledgeable. So it is quite important to understand what is the satisfaction from patient and staff. The study also found a very good patient and staff satisfaction. About 95% of the patients accept the user fees, and the satisfaction rate is quite high, about 72%. Next slide. To summarize, next slide. We found quite mixed evidence of the user fees in terms of the utilization of the healthcare. There's no conclusive evidence for or against the user fees. To introduce or abolish user fees is a very important decision to make for policymakers, but at the same time, it is also quite important to regulate how user fees should be used in order to make sure the quality is improved. When introducing user fees to mitigate the inequalities, it is necessary to develop alternative policies, such as exemption policies, health equity funds for the poor, so the poor are not left behind. Lastly, we know that a lot of countries are considering abolishing user fees. We should always keep in mind, if the user fees are abolished, some other money should come in to fill the gaps. There's no free lunch for healthcare. Next slide. Thank you very much. I will stop here.
Thank you so much, Dr. Wu, to guide us through the international experience of user fees. And so we've learned that the results are mixed depending on the country. So maybe it's just time. We've said we will spend some few minutes just to ask some burning question on the presentation. So I got some question. So the first question that I've got is that you've been talking about the importance of quality improvement when there is user fee introduction. So would you have any example of some quality measures that have been implemented that can explain increase of utilization after the reform implementation?
Sure. I'll just use the example that I mentioned during the presentation. That is the study in a hospital in Cambodia. So in these hospitals, when they introduced the user fees, they also launched a program to improve the quality of care, which is they call the continuous quality improvement, which to first examine what are the major quality issues in hospitals, and then adjust it accordingly from a managerial perspective or from a financial resources perspective. So as you can see, some of the funding, about 20% is used to adjust the stock out of the medications. That is one way one approach they identified as the major quality concerns for the patients. By adjusting the stock out, more patients are like trusting the hospitals, and then they are able to come to the hospitals to seek care.
I have another question. Do you know from your study what is in that case that you've presented in Cambodia? What is the percentage of the total cost of the facilities that was recovered through user fees?
As I recall, it's quite high. It's about 40 to 50%.
Okay.
Yeah.
Okay, so maybe I think, let me see, there are questions entering. So I'm reading as they're coming in. So we have a question from Stefan Batz, who is asking, in Ethiopia, the largest improvement with introduction of user fees was that the doctor actually remained at the hospital rather than working elsewhere. So I don't know whether you want to comment on this, if this is something you also observed in other countries.
I think it's, of course, there are a lot of issues regarding human resources. I think in a country with a large donor fundings, there's a huge brain drain from public sectors to the private sectors. I think the part of the, user fees can probably used to partially address these issues. The reason why people move from public sectors to the private sectors is because of low salary, because of lack of the incentives. I think with the additional resources coming to the health centers or hospitals, user fees can also be used to raise the salary to retain the quality medical personnel.
Thank you. We have tons of questions. We can't address them all right now. We'll try to seek answer and respond to you maybe at the end if we have a little bit more time. But I think it's time maybe to move to the Cambodian experience, and many of the questions that also are arriving concern Cambodia. So I will pass them on to Dr. Jordan Hood. Thank you, Dr. Hu. Let me now give the floor to Dr. Jordan Hood, who will tell us a little bit more about the user fee in Cambodia and especially the health equity fund system that has been put in place. Dr. Jordan Hood is yours.
Thank you very much, Caroline.
Okay.
And thank you very much for the privilege today to make this presentation. Today, I would like to review the introduction of user fees here in Cambodia, which thankfully Dr. Wu has provided us with a great introduction, and then move into some of the dynamics that have occurred with that introduction and the reactions, especially around the introduction of barriers to care that were experienced by the poor and how Cambodia has dealt with that through the Health Equity Fund system. So if we could go to the first slide, please. So until 1996, officially, public health services were free for all in Cambodia. It meant that there were meant to be no out-of-pocket payments by patients when receiving services. We also had a situation where the salaries of providers were incredibly low, and in order to make a living wage, they had many private practices, often located right outside the front gate of the hospital. And within the hospital, we saw high levels of informal fees, with one estimate done in 2004 that it was up to 45% of the facility revenue was coming in informal fees. So this worked for the staff, but it was really bad for facilities, especially facility managers who wanted to organize services in a rational way, and it was incredibly harmful to patients. Next slide, please. So the example provided by Dr. Wu is the National Maternal Child Health Center, which I think was part of the early experimentation of introducing user fees, which were then codified into something called the Health Financing Charter of 1996. Caroline, if you could go back to the previous slide, please. This charter allowed facilities to introduce user fees. And they were supposed to set those user fees individually by consulting with their local community and then submitting it to the Ministry of Health for approval. Now, initially, there was a breakdown of how you used that income, which included 50% for staff incentives and about 49% for quality improvement activities or purchasing additional drugs and supplies, as detailed by Dr. Wu, and then 1% a remittance back to the Ministry of Economy and Finance. This was later amended, I believe, in 2005 to have 60% for staff incentives, 39% for facility running costs, and they kept the 1%. And within this charter, it required that facilities put in place an exemption system for the poor. But they didn't fund that. They didn't provide any cost reimbursement for when a facility decided to give services to someone who's poor for free. Next slide, please. So local governance was meant to play a big role in this process. And this worked pretty well at the health center level, because in Cambodia there's user fees at both the primary level and hospitals up to the national hospitals. So at the health center level, this worked pretty well. There were local communities, there were health center management committees, and the structure of services at a primary health care center is relatively simple. At the hospital, this was a lot more difficult because obviously services there are much more complex, and community members often don't have a background that would allow them to provide meaningful contributions into how to set fees. Next slide, please. So what did we get? We got a huge amount of variation, not only in the structure of how those user fees are put together, but in the prices. So in some hospitals, we have package pricing, where a complete hospital stay may have only one price, whereas in others we had a complete fee for service, where you paid for every single service that you received. Also, the prices are wildly different, with some areas strongly believing that health services should be affordable, whereas others are maximizing their potential income. They did require that the user fees determined and approved by the MOH be posted on a signboard at the front door of the facility. And this was a really important step, especially in the context where we had very high levels of informal payments. So it took a while, it took more than 10 years, but by 2008, nearly every health facility in the country had established their user fee scheme. Next slide, please. So this was good in general, because the user fees that were posted at that front door to the facility were generally lower and obviously much more predictable than the informal fees that people were used to. And so even though it's an introduction of user fees into a system that's supposed to have free care, in actuality, in reality, the price of services went down and the empowerment of clients went up. We did see increases in utilization. We saw increased focus and attendance by provider staff, and that the supply of maintenance and supplies and drugs had improved. And because people felt empowered by that signboard at the front door that said, this is how much it will cost, they were much more resistant to pay the informal fees that they paid previously. And so we saw a dramatic reduction in informal payments. All of the money that is collected by user fees is kept at the facility. And with 60% of that money being used for salary supplements, we did see increased salaries for health staff. There is guidance in how facilities are supposed to distribute to the health staff, but in reality, there's a wide variation in how they do it. This was a huge help to facilities that were experiencing erratic budget disbursements from the Central Ministry of Health. And in general, here in Cambodia, we see the introduction of the user fees as a good thing. Next slide, please. So, the bad. Exemptions were built into the health financing charter, but they were very poorly defined. They were incredibly loosely defined. It simply said, take into account their economic situation and give them an exemption if they're poor. So we have a huge amount of variety in how these exemptions were defined, how the process of providing them was organized, and variation between facilities and how many exemptions they decided to give. A big factor in this is the basic concept here that these exemptions are unfunded. And with the money from user fees staying in the facility and going to salary supplements, in effect, this meant that the Ministry of Health was asking individual providers and facilities to fund those exemptions out of their own pockets, out of their own revenues. And that is the incentives there are not terribly great. We also saw some bad behavior where people would be charged user fees until they ran out of money, and then at the last minute they'd give them an exemption, knowing that there was no more money to be taken out of their pocket. Next slide, please. So in reaction to this, in about 2000, a series of pilots were started to actually purchase services for poor people who were unable to pay for healthcare in hospitals. And this was, at the very beginning, started as a way of addressing the occurrence of catastrophic healthcare costs. This idea grew over time. It was seen as a way for development partners to purchase services from the public health system and at the same time leverage quality, given that they are now a bulk purchaser of services. By 2012, what was a wide variety of pilots had become standardized. And by 2015, we were able to expand the system to all health facilities in the country, which currently provides free health insurance to about 3 million out of the total population of 15 million. Next slide, please. So the poor are identified in two ways. The first method is done by the Ministry of Planning, which has a rolling process whereby local commune councils work with individual villages to identify poor households. A household here is defined as a group of people who live together and eat from the same pot of rice. When they're identified as a poor household, they're given the card that you can see on the top right, which is called an equity card. And that card is meant to entitle that household to a wide variety of services, not only health, but possibly education, agriculture, food subsidies, and so on. That card's good for 3 years, at which point there would be another round of the identification process, and it goes on like that. This has been working since 2006. It covers the whole country. Now, obviously, there's going to be some people who are missed by that since it's every 3 years. And so at the hospital, under the Ministry of Health and the Health Equity Fund, poor patients who cannot pay their hospital bill can be interviewed and awarded Health Equity Fund benefits on the spot if they qualify. The benefits that they're awarded are exactly the same as if they have a card from the Ministry of Planning. the validity of that card lasts for 1 year. Both of these cards can be used nationwide, as the benefits that are awarded are completely portable across the whole system. Next slide, please. So what exactly are the benefits? They include a full payment of the service fees, which is done directly to facilities. During the conceptual design of this system, we wanted to make sure that the patients did not have to pay anything out of pocket and then seek reimbursement. They simply come into a hospital or a health center, present their card, receive free services, and at the end of the month, the facility gets paid. Also, in addition to the service fees, if they're accessing a service for outpatient or inpatient services at a hospital, or they're delivering a baby at a health center, they'll receive a round-trip transportation reimbursement, which is calculated based on the number of kilometers from their village to the facility. For patients who are inpatients, they get $1.25 a day as a caretaker food allowance. To be in hospital in Cambodia, you have to have a caretaker with you who cooks and cleans for you. And this simply supports that support person. There's a small benefit if you are to die in hospital. And as I said earlier, this is portable across the whole country. Next slide, please. So this is a graph that simply illustrates the growth of the health equity fund system over time. It first went to hospitals. You can see in about 2008, it really started to go into health centers. And the FDH stands for former district hospital. These are essentially primary healthcare centers that have beds. So they offer a slightly a bigger package of services. The black line is the operational district, or the health districts of the country. And you can see by 2015, for all operational districts and primary care facilities, we reached full coverage. And we've now reached about 90% of the hospitals. The remaining hospitals are the national level hospitals, which we're about to expand to 3 more, but these are big cost items to the health equity fund system and therefore require a lot of negotiation. Next slide, please. This is a slide that's going to show you the relative contributions of financing into the health equity fund system. And it shows you that here in 2016, the total cost of the health equity fund system for 3 million people is about $16 million, which, getting back to a point made by Dr. Wu, you can see it's only paying a portion of the overall cost of care. We also see continual and dramatic improvements in the level of funding coming from the royal government of Cambodia, who has clearly adopted the health equity fund into their poverty reduction strategies and their health sector strategies, and have committed to funding the system in full by 2020. The red are pooled fund donors that have contributed through a variety of 3 different mechanisms to the system over the years. And then finally, there's USAID and the Belgians, who have been providing most of the TA to the Ministry of Health in their stewardship role. Next slide, please. Next slide. This is just to give you a quick picture of, this is from a hospital, and the card in the plastic bag is from the Ministry of Planning. And the woman here is working for the Health Equity Fund and is officially admitting this patient into the hospital. The hospital has already determined that this patient should be admitted, but they've now gone to the Health Equity Fund desk for confirmation of their eligibility. And then the form that you see her filling out is a summary of treatment form, which provides a very summary level of medical information, but is mainly used for billing purposes within the Health Equity Fund system. Next slide, please. This next picture shows the form that's used to distribute the caretaker food allowance of $1.25. And so this is clearly the thumb of a caretaker. Probably one of his family members is in the hospital. I think his wife had just given birth. And he's receiving his $1.25, which is delivered to him bedside. It also gives a chance for the Health Equity Fund to ask patients, have you seen the doctor today? Have you had any problems accessing care? Do you have any questions? And so the Health Equity Fund also is a patient ombudsman service to help people navigate through what is often a very confusing and complicated place. Next slide, please. So at the very beginning of the whole system, the Health Equity Fund paid the user fee prices. And for a while that worked because it was only a few facilities. But it quickly went in the wrong way because hospitals realized that the Health Equity Fund had a lot of money and that they could raise their user fees and get more money from the Health Equity Fund. So what we started working on are case-based payments so that the hospitals and health centers are paid an average price per patient rather than the actual user fees, which are often fee for service. And this has helped us to standardize the system so that now the Health Equity Fund pays the same price for every service at every facility. Those prices are different at different levels of the system. Health centers are cheaper and hospitals get more expensive as you go up the ladder, but they're standard across the country as opposed to user fees, which are not. Next slide, please. So some final thoughts. I realize I've reached my 20 minutes. Things that you should consider when thinking about user fees with Cambodia as a case study in mind. When introducing those user fees, what kind of balance are you trying to strike between income derived from people's payment out of pocket versus the income that a facility will receive from the supply side, from budget or in-kind supplies and drugs? How are you going to protect those who are unable to pay? I think Cambodia provides a good example, but obviously there's other ways to address it that contextually fit each country. And how can we develop provider payment mechanisms that balance incentives such that we avoid moral hazard? At the same time, think about how introduction of user fees or other provider payment mechanisms affect providers as well as consumers. And I think that's all from me. Thank you very much.
Thank you so much, Dr. Jordan Hood. I think it was excellent to learn about the experience of Cambodia and trying to give some advice for those that are thinking about implementing such reform. I have a lot of questions. I'm conscious of time, so I will just ask you one, which is about the cost of the exemption mechanisms. So the question is about how expensive it is to put in place such exemption policy, and what are the best mechanisms to identify the poor.
The exemption system we have in Cambodia is not very well documented. Oftentimes when exemptions were provided, they weren't documented. We also, as I said, have a huge amount of variety in how exemption systems were designed facility by facility, such that it's hard to generalize, except that we do know it was a disincentive to providers to give out exemptions. And so I would urge that in the design of any exemption system, number one, you think about making it a funded exemption system rather than an unfunded one. And secondly, think through some standard processes and tools that you can give to facilities to use in that process, as well as clear documentation that will allow you to monitor how well it's working or not working.
Okay, I think I'll stop here because I have a lot of questions concerning how the example of Cambodia can relate to Afghanistan. But before moving into those sets of questions, let me maybe invite Dr. Firewar to just give us a bit of background of where Afghanistan stands in terms of the user fee reform, as well as some expectation of what the reform is willing to achieve. Thank you so much, Dr. Jordan Hoon, and see you for the question and answer.
Good afternoon, everybody. This is Farhat Fariwar, Acting Health Economics and Financing Director. After discussions of Dr. Hu and Mr. Topley, I think it is time now to discuss some and brief on the Afghanistan path towards implementation of the user fee. In this brief presentation, I will cover the current source of financing in Afghanistan, current status of hospitals financing, what do we really want to achieve with implementation of user fee in national hospitals in Afghanistan, and also I will touch on user fee reform, and then we'll ask some key questions from the audience. First, on the source of financing in Afghanistan. Unfortunately, Afghanistan is one of the countries that, according to the NHA 2014, most of its health financing burden lies on the shoulder of the communities, meaning that 72% of the total health expenditure is being paid out of the pocket, which really put people at risk of being impoverished, and also does not provide any opportunity for risk pooling and also solidarity between the people. Next slide. Unfortunately, despite currently most of the hospitals financed through SEHAT have a fairly good quality of services being provided to rural and provinces, but the national hospitals are currently underfunded, and also the way they are paid does not provide any opportunity or flexibility for the hospital to provide services as needed. And also, it's perceived that the informal payment is prevalent in the national hospitals. And according to the benefit incidence analysis conducted by HFD in 2013, it is indicated that the national hospitals are pro-rich. As a result of these underfunding of the hospitals and also the perceived low quality of services in the national hospitals, the people prefer to seek quality health services elsewhere, either in the private sector in Afghanistan or outside the country. Next slide. What do we really want to achieve by introduction of the user fees? One of the reasons that justifies introduction of user fee in Afghanistan, that we want to improve quality of hospital services in national hospitals to make sure services are to the satisfaction level of the people, and also avoid some of the health expenditure that is otherwise incurred outside of Afghanistan. Also, increasing access and utilization of health services financial constraints of the hospital, solving them, as well as the improving efficiency, as Dr. Hu mentioned, and rationalizing utilization of health services by curbing some of the unnecessary use of health services, and also improving transparency, because we believe that by charging formal user fee, we could avoid some of those informal payment that would otherwise be charged. Next slide. After amendment to health law was approved in 2014, now Ministry of Public Health is in the process of finalizing its user fee regulation, which is under process. And the next step would be to develop the guideline in close collaboration with our HSR colleagues and our partners. So this is a good time for us to learn from other countries and also other experts in the field of health financing and economics to make sure what we want to achieve is, yeah. Next slide. With this, I'll put forward a number of questions to the audience. Actually, this is what the Ministry of Public Health wants to address before going forward with the implementation of user fee. And also, we want to make sure that the poor are not discouraged due to charging user fee at the hospitals. And the second thing, whether there are services that we should keep it free at the secondary and tertiary level to promote its use. And also, what are those quality improvement measures that we claim that justifies the charging user fees? And also, for the sake of solidarity, how and whether it is possible to use some of those resources generated from the better-off communities to the areas where it's not better off, and how revenue collected be managed, and also some of the accountability measures on the use of user fees, and also then there is also concern about the transparency of charging user fee, as well as the when we use it for the improvement of quality of health services. So these are the number of questions, and with that, I'm done here, and back to you, Caroline.
Thank you so much, Dr. Faiwar. Thank you to all the presenters to give us some more insights and fruitful discussion. So now we are opening the question and answer session. I've received a number of questions, but maybe let me first try to address the ones that not myself, but try to put forward the ones that Dr. Faiwar mentioned as the key ones that the ministry is willing to consider before implementing the user fee. So maybe I would like to ask to Dr. Wu, if Dr. Wu is still here, on the first question. So we've talked a lot about the Health Equity Fund as a way to exempt poor for paying user fees, but are there any other mechanisms that you've encountered in your review, and what were the pros and cons of those?
Yes, I'm still here. So I think there are probably also other approaches to address issues regarding equity. I think currently there are a lot of approach has been mentioned related to like subsidizing the demand side. For example, the voucher schemes. Basically, these schemes can be used as a way to, in combination with the user fees, instead of subsidize the health centers through health equity fund or through exemptions, and incentives can give to the patient directly to give them vouchers when seek care, so that they can give these vouchers to the hospitals or health centers and use as a payment. So in that way, there are some studies that compare the voucher schemes versus the supply side schemes, and there is some advantage of the voucher schemes in terms of reduction of those some stigmas.
Great. And while you're still there, I would also like to talk a little bit about the question more on the supply side. So about the experience about the fee management, the collection management from the review you did. What's the most common management practice? Are the user fees always managed at the facility level? Is the money in general transferred to central level? And have you heard about any pooling mechanism to ensure that the facilities in the poorer area are benefiting from maybe higher collection in better off places?
Based on our review, we saw a lot of literatures regarding the impact of the user fees, but the management of the user fees and how it is collected, how it is used, how it is retained, there's no too much documents out there. So the only one we found that actually is it's in Cambodian case, which Dr. Jordan Wood has mentioned. Most 99% of the user fees are retained at the health centers. Only 1% goes to the central level.
And Dr. Jordan Hood, so in Cambodia, so the money is kept at the facility level, but are there been any discussion about how this money could be pooled?
No, there hasn't been any discussion about that. It's very much seen as money under the control of facilities. That's in the context of erratic and declining budget disbursements, which makes them more and more reliant on user fee and health equity fund income. So there's been zero discussion about pooling or reallocation to poor facilities, for example.
And I have a question as well regarding the government budget allocation to hospital. I mean, the introduction of health equity fund and user fees, did it impact negatively the allocation that the government was giving to hospitals?
It's very difficult to know, frankly. We have a lot of information about budgets, but we have very little information about actual disbursements. In 2012, we did a comprehensive hospital costing study, which looked at 12 different hospitals. And the biggest finding we had was variation, huge variation. And it was difficult to discern if even the supply side allocations were based on a formula that would take into account population covered or particular types of services that are being provided. It was erratic in every way. And so we don't have good information other than anecdotal evidence that disbursements are very erratic.
Okay, maybe a question for you, Dr. Farwa. I have question or concerns about the figures that you've shared about the 72% of total health expenditure coming from out-of-pocket expenditure, and some attendees were questioning how the user fees will really help decrease this percentage. How do you see the decrease happening?
Mm-hmm. Caroline, thank you. Very good question. I don't think if there is a very direct link between the user fee charges and reducing out-of-the-pocket payment, but with the user fee charges, we believe that we improve quality of health services at the hospitals, and also some of those otherwise need that would be fulfilled by the private sector and at a very higher cost could be fulfilled there in the hospitals at a very lower cost and a partial user fee, which would necessarily not be equal to the price of the price in the market. At the same time, also, with the charge of user fee, we will curb some of those informal payments at the hospitals that would otherwise be very high to the public.
Yeah. And I have a set of questions.
And also, the next thing that we want to address is which is very political, also seeking care abroad due to low quality of health services. This is some of the things that destroys the reputation of the government of Afghanistan.
Yeah. Maybe Dr. Jordan Hood, from the experience in Cambodia, is there any correlation between the out-of-pocket expenditure that is spent and the introduction of user fees and later on health equity fund?
I don't have evidence about out-of-pocket expenditures before and after the introduction of user fees specifically. I haven't researched that in preparation for this webinar, but I do know from research done on the Health Equity Fund that we have seen reductions in the occurrence of debt for healthcare and the size of loans that people take for healthcare and the eventual repayment of those loans, which has been studied quite extensively in peer-reviewed journals. So we are seeing an impact from the Health Equity Fund. But remember, the introduction of user fees here was quite an early period in Cambodia's development of its health system, and we don't have a lot of evidence from that period.
Okay. I also have a lot of questions. We've been talking a lot about the pause, but it's true that depending on the targeting mechanism as well as probably the funds that are available to sponsor them, there is a big portion of the population that will have to use user fees. So I have some questions and concerns from Afghanistan to say, how will we be able to pass this reform, and even if this is small amounts to be paid, how will that be accepted? So maybe I can continue with you, Dr. Jordan Hood. Just I know you were not there at the introduction, but if you have any insights to give into that, and then maybe Dr. Farwar, you can continue to explain a little bit how Afghanistan is planning to prepare the public for this new reform.
With the introduction here, it really was rolled out almost facility by facility. And there were these large community meetings. I arrived here in 2001 and actually was able to go to a couple of these meetings where the user fees were being discussed. There was a lot of input from community members, although it tended to be quite broad-ranging. And then it seemed more of a political discussion between local authorities and facility managers as to what would be acceptable for their local situation. Again, the story from Cambodia is huge variation, and that not something that you possibly want to repeat.
And Dr. Farwar, is this something that has been, is there a discussion at the ministry on how you will tackle this dissemination, this information to the public?
Caroline, to tell something about the current status and also the intention to go forward, I would like to say that primary healthcare services for which most of the people are concerned about charging user fee will remain free. At the same time, in Kabul, where we wanted to charge user fee at the national hospital level, we will also run an urban health project, which really provides primary healthcare services to the people. So we might not have a big concern on some of the poor if they were denied services at the hospital level. So as I said before, the health law is amended, and also it is legalized that the government or Ministry of Public Health is allowed to charge user fee on secondary and tertiary services. At the same time, we also have the user fee regulation under process, and there is high-level support within the government of Afghanistan and also at the Ministry of Public Health level to charge user fees as soon as possible. This is also one of the issue of very high interest at the hospital management level as well. So we plan to start it small, say 2 or 3 hospitals, and then we want to scale it up. We have a project called Hospital Reform Project, where they already charged user fees and they have also an experience of implementation of user charges. So they believe that as soon as the user fee regulation is passed and a guideline is developed, they will implement the user fee without any support from our side.
Okay, I also have a lot of questions that are, sorry, someone wanted to say something? So yeah, I have a lot of questions that are about the level of user fees that needs to be put in place, because in the Afghani case, it seems quality is quite low, and attendees are just saying that if we want to improve quality, we probably need to have significant amounts coming in, as well as if we want to motivate staff. So I don't know, maybe Dr. Wu, if you're still there, if from your also from your review or your knowledge, is there any practice that or advice that you can share on how to set the user fee prices?
Can you hear me? So,
Yes.
great. Thank you for the question. I think the comments is quite valid. If we need to improve the quality substantially, it need much more like a larger financial support. And I always think it's quite important to start with the small, even for the quality improvement. The health centers might have different quality issues. Hospitals, health centers, and health facilities need to identify what are the key major issues, and then use the resources, which is quite limited, to target those quality concerns, then to attract a patient. I don't think with the amount of user fees coming in the health centers that health center or hospital can have a large like a quality programs. It can provide resources to initiate more targeted quality improvement interventions.
Okay, great. Maybe another set of questions, and then maybe we'll end after that. But some a bit more. First, I have a comment on how to deal with the pooling somehow question that we had before, and the difference in terms of the revenue that can be collected in rural versus urban. So it seems there is an incentive mechanism that is in place in Cambodia. Maybe you can tell us a little bit more about that, if you know about it, Dr. Jordan Hood.
Well, I mean, I think you're talking about the incentive mechanism that the user fees collected within a facility are then shared amongst the various providers and workers within the facility. Is that what you're referencing?
I think it's not from my knowledge, from the comments I received, my understanding is that there is some kind of incentive mechanism where probably there is a bit more money, maybe through the government budget, that is allocated to rural facilities.
Yes, that's a relatively new thing. Okay, so health financing in Cambodia has a wide variety of initiatives, and it has permutated into an incredible number of sources of income that facilities receive for a wide variety of things. There's, for example, a live birth incentive that provides $15 to a health center for every live birth and $10 to a hospital. There's something called service delivery grants, which are meant to be performance-based financing agreements that end up as salary supplements. There's block grants that are being introduced in the very near future, as well as the standard budget allocations for salaries and travels and per diems and such. That in itself is a whole nother discussion. Not quite sure how to tackle that.
Maybe the takeaways because that was a key question that Dr. Farwa put out there, how to deal with this inequity between facilities. So probably your response is that there are other policies than the user fees maybe to address that. So that should be tackled in a different way.
And a key part of that is coming up with a standardized approach and methodology that can ensure that you anticipate inequities before they happen, or give you the control to address inequities after you monitor for a bit and see what's happening. The problem with user fees here is that it was completely devolved down to the facility level to determine the structure and price level. And so we've got a huge amount of variation with some hospitals that clearly are using user fees to generate absolutely as much revenue as they possibly can, whereas others are keeping their rates incredibly low. And that creates a real tension, I think, within the system that could be addressed by the central level if they had thought about that from the beginning. So that's a lesson learned, I would say.
That's nice. I think that's a nice maybe ending words from the Cambodian experience. Maybe I'd like just to turn on to Dr. Wu. I don't know if from your literature review and the discussion there is one key message or some final points that you would like to provide maybe to the Afghani ministry and other attendees that are with us today.
So basically, I think I just want to reiterate during my presentation, user fee, we need to care about the user fee, the price impact. At the same time, we need to also have regulations on two major issues. One is how user fee is used to ensure the quality of the improvement will take place. Another is to adjust the quality the equity issues to have policies like exemption policy or equity fund or voucher schemes to adjust the inequalities to mitigate the negative impact of the user fees.
Right, thank you, Dr. Wu. Maybe Dr. Farwa, if you would have some last words that you would like to say to close that event. Or if there is one key burning question you really want to ask to our panelists.
Just to talk on some of the questions that was asked from the other participants as well. And then with that is, for instance, like about the costing, like setting the prices on the hospital, the hospital services. So far, HAFD has conducted 2 rounds of hospital costing, which gives us some clue on the amount of cost each service might require. So, and also at the same time, in the guideline, the amount that is set on each, or the price that's set on each service is so low that is almost insignificant. Because we are hoping that this will be a supplement on the hospital budget and not a replacement. That is somehow we assume that's happening there in Cambodia, because they are just financing the hospital through the user fee. But what we want to do is, we hope we can keep the hospital budget while supplementing that with the user charges. And the last point is that we will certainly discuss, because there has been a number of questions that we didn't discuss here. So we will discuss that one as well, and also share with the panelists for a response. That's all from my side.
Okay, well, I think it's time to close this first event, this first webinar. I want to thank all the presenters for the time that they've put in setting this event together. I hope you've enjoyed, I hope you've learned, and I hope you will continue to join us. So the Health Economic Exchange Forum has a website. Please do register. You will find some information about health financing in Afghanistan and in the region, and you will find some information about upcoming events. We'd like this to be the first of a series, so we'll be soon in touch with you to let you know about the next topic we'd like to have discussed together. Thanks everybody. Thanks to the HSR project, and thanks to the Ministry of Public Health. Thank you. Bye.